We have amongst us a surgeon par excellence and a passionate academician, Professor Dr. Satish Jain, ENT, head and neck cancer and skull-base surgeon, Jain ENT Hospital, Jaipur, an eminent scholar with an illustrious career spanning over 2 decades. Dr. Satish has done pioneering work in the development of endoscopic and microscopic skull-base surgery, initiated cochlear implant program in Rajasthan, and has several other merits to his credit. Parading the achievements of this renowned academician is, of course, a biographer's delight. With all cordiality and respect, we welcome Dr. Satish Jain for his session on light surgery, basics to advanced. With that, I request you to give your undivided attention to Dr. Satish Jain. We welcome you, sir. The first surgery will be chaired by Dr. Sajid, AOI State Secretary and Senior ENT Surgeon Manjeri, and Dr. Saduddin Ahmed, Head of the Department, Kottayam Medical College. Thank you.
Hello. Hello.
Yes, sir.
Hello.
Yes, sir. We can hear you, sir.
Hello. Am I audible?
We can see you, sir. We can hear you.
Thank you. Good
Yes, sir.
morning, all. And first of all, I extend my thanks and gratitude to the organizing team for giving me this opportunity once again to share my thoughts and, learn more from this very high-end conference from the Kerala state. And as we all know, we know this dictum, well begun is half done. And that is what we see this morning with a fantastic, informative lecture from video lecture from our friend, dear friend Manoj. It was really mind-blowing to see the fine details, fine crux of cochlear implant surgery, who himself is a master in this field. And we learned a lot from that. Thank you so much, Manoj. And once
Good
again,
morning, Satish ji. I am Shahid and Dr. Sadruddin is chairing the session.
Hi, boss.
Both.
Thank you, Dr. Sajid.
Thank you. We welcome you to this CanCon. We love to be here in physical presentation, but I know that you have to travel to Hyderabad and also it is very difficult to arrange all this here. But you have got a fantastic setup. We know there. We can telecast anyway from there. Thank you for inviting our, coming to CanCon. Thank you very much.
Over to you, sir.
Thank you. Thank you, Dr. Sajid, once again for giving me this opportunity. And I welcome here Dr. Sharif, who is from Kerala State, to be here in our theater today with us as a member of Kerala State ENT Association. Really nice to see him here in the theater. So as I said, well begun is half done, and thanks to Manoj for this mind-blowing lecture. Today's session, we have, cases lined up as the organizing team, spoke to me. And I am indeed, so glad to meet those people wanting to deliver maximum possible to the delegates. So they discussed a couple of times to bring out variety of cases to incite more and more discussion. So we are beginning our day with the basics, with the case of nasal polyposis, and plan is a full house sinus surgery. So I'll take you first to the CT scan, which I call as a Google map for the, paranasal sinus anatomy. And that will definitely help us to, carry out the sinus surgery with utmost safety and preventing complications. After that, we'll have otology case, like we have a small acoustic neuroma. I didn't keep the large one. We had 3 cases of acoustic today. So the small one I have kept for demonstration. Then we'll have some other cases like inverted papilloma, especially frontal sinus inverted papilloma involving the orbit, some tympanoplasty, revision rhinosporosis, and some more revision FAS and other cases. So let's see how much we can go till 4 o'clock. So to begin with, are you getting any imaging picture?
Yeah, we can.
So This is the basic, CT scan of the patient. One thing I always mention, and I will reiterate again here, to order a CT scan in a digital format. Order a CT scan, some millimetric sections. A paranasal sinus CT scan we all require is a non-enhancing CT scan, because we are looking for the getting this for the inflammatory disease of the paranasal sinuses, where we don't need a contrast enhancement. So what we need to order is a fine some millimetric section like this. You can see in the corner here, it is 0.6 mm sections in axial plane. It is always shot in axial planes. And then you can reformat, reconstruct in your own software. This is DICOM, you can download from Google, and you get three-dimensional imaging, that too dynamic, to get maximum details of this paranasal sinus, labyrinth, you can say. This area is very, very important. Let me show you why this is important, why we are so concerned about. See, paranasal sinuses are all around surrounded by orbit and skull base. All the way, orbit and skull base are in close proximity. The threshold of safety for this surgery is very low if you are not oriented all the time. There are so many structures running in close proximity to the limits of the paranasal sinuses, like carotid artery, optic nerve, cavernous sinus, many cranial nerves, and so many things. You have to be ultra oriented to prevent complications. And the only thing which helps you is a three-dimensional CT scan. Unfortunately, many a time patients come to us with a printout of a scan, that to a coronal scan only, majority of the times. And why it happens? The reason is very simple. It all depends upon the surgeon how he orders the CT scan. You write a CT scan PNS, that's it. What will radiologists do? Radiologists will do 5 mm section in less than 10 seconds with 10 or 20 slices in a printout to give you that this is your CT PNS. Now, how much informative it is, you know very well. So what kind of CT scan should be? See, this is 0.6 mm section. Every time I move with 0.6 mm. If I reconstruct to a coronal one, see this. This is 0.4 mm in reconstruction now. Now, every time I move with 0.4 mm. See this, every time 0.4 mm, so I don't miss any submillimetric anatomy. That is the basic reason. Now imagine, in the area of the paranasal sinuses, in one section, like in this, you have seen 116 slices. 116 axial, coronal, sagittal around 350 or something. Then in a bone window and soft tissue window differently will be double, and it is so impossible for a patient to carry on printouts, and equally impossible for the surgeon to look at all those slices. And that too, is not up to the mark. So what kind of CT scan we need is a dynamic one. Dynamic one you can run, and you can see each and every anatomy, so dynamic. Like, for example, let me show you why it is important. See, I am coming from anterior to posterior coronal section. What I see here is the frontal sinus. Then two cavities, looks like intersinus septum deviated to one side. Some opacity here. Now, as we go behind, we see another intersinus septal. Now, see, if you get in this printout, this is intersinus septal cell. We don't know which sinus this is opening into. We need to know, so that we can widen to see the intersinus cell, or we can communicate in surgical session. See this intersinus septal cell is communicating to the right sinus. See how easy it is for the dynamic CT to understand and give information to you. So number one is dynamic CT. Number two is three-dimensional. Three-dimensional dynamic CT is the only reason we go for CT scan like this. For example, see this. Any structure in coronal plane we know, we easily understand in coronal plane, because in the same plane we operate as well. So it is easier to relate the anatomy in coronal plane. Now there are certain anatomy which is best, depicted, or more details are given in the axial plane. Some anatomy, the best details are depicted in, sagittal plane, like frontal sinus. Frontal sinus is best seen in sagittal plane. Now, see, this is intersinus septal cell. How it is related to the frontal sinus? How it is look like on the axial sagittal section? See this. This is your intersinus septal cell on coronal. Take your cursor there and see where is the intersinus septal cell and how it can interfere with the drainage pathway of the frontal sinus. So all you can see when you relate three-dimensionally. The point is, what I'm trying to say is, this should something we can make a habit or a practice to order a CT scan in digital format and then see dynamically so that you don't miss any single fine submillimetric anatomy, which is important to prevent complication, important to carry out a complete surgical procedure. Otherwise, not knowing the fact, this fact is always makes you in trouble or makes you in doubt whether you are close to some critical structure or not, or either you're likely to do an incomplete job or you'll end up with some complications. So we have to be very to stay very close to the perfection. We need to have a complete information of CT scan in the dynamic format. Do you agree with me?
Yes, sir. Yes, sir.
So, like coronal section, I'm not going in details of the CT scan right now as the case is ready. But yes, I'll touch upon some important issues which we need to see on CT scan and some positive findings in this particular patient. Coming from the most anterior to the posterior. See, the first thing, the bony septum, the higher bony septum is little deviate to the left side. And you'll see in the rest of the, see, the right nasal cavity is more roomy as compared to the left, and this high deviation is something need to be corrected. Why I am showing on CT scan this high deviation? Because this is the time that you can have this thing in your mind and you can counsel your patient that will require an additional septoplasty as well. What happens sometimes intraoperatively, you decongest the node and you feel like there is hardly any room, hardly any problem in carrying out the sinus surgery, even on this left side after decongestion, and you can go ahead. Now passing your instrument through the narrow passage can actually cause trauma on both sides and can lead to synechial later on, which is something counterproductive for the sinus surgery, as entire sinus surgery success depends upon the ability to introduce post-operatively the topical irrigations. So in this, from the first picture, you can make up your mind and tell your patient in advance that you'll need a septoplasty as well. And I can show you if you want how a limited septoplasty can open up the space on the left side. So this is first thing, you need to see the nasal septum. Then coming from anterior to posterior, the first thing what you come across is the stigmatization in the frontal bone. There are two spaces with an unequal size of the frontal sinuses. This is intersinus septum, which is rarely in the midline. And these are frontal sinuses. Why I'm saying frontal sinuses? This is two anterior anatomy. Two anterior are frontal sinuses. And why? Because there is floor intact and this floor is formed by beak. Let me take you what I'm saying to the three-dimensional. See this, where I am. This is frontal sinus and this floor is formed by beak. Can you see this?
Yes, sir. Yes, sir.
Hello?
Yes, sir. Yes, sir.
So beak is why I'm emphasizing on it. This beak is going to be our single most landmark to find the frontal sinus, to enter into the frontal sinus in the safest way. That is what I will corroborate intraoperatively as well. See, when you come with your endoscope from here, with a 70 degree suppose, the first thing you come across is the beak. And as you go behind the beak, see, as the beak ends, as you go behind the beak, what is this? The frontal drainage pathway. Can you see?
Yes, sir. Yes, sir.
The frontal outflow, the single most important anatomy you can, consider in your practice as the most reliable landmark is the beak. That is what I'm going to show you. In any of the most difficult frontal sinus situation, the beak is almost always there. In any number of revision surgeries done, beak is hardly disturbed. So it is always there as a landmark. And this is a God's given landmark which is never going to change. You follow the beak, follow the beak, follow the beak. Where the beak ends has to be the frontal drainage pathway, nothing else. So this is what I'm going to corroborate. Now see in the coronal section what I was seeing. As long as the beak is there, see this, as long as the beak is there, the above pneumatization is the frontal sinus. See the beak is still intact, that is intersinus septal cell. Beak is still intact, now the beak is gone. And see what is this? This is frontal drainage pathway. Can you see very clear?
Yes, sir.
Now the frontal is gone. See this, until now it was frontal sinus. See now it is until this was frontal sinus. Now the floor has gone, the beak has gone. Until now you don't see the maxillary sinuses in view. So simple. And now as you go behind, as the frontal recess appears, the frontal drainage pathway appears, see the cribriform plate coming into picture. That is the ethmoidal roof. That is called anterior ethmoidal roof. The anterior part of the ethmoidal roof immediately behind the frontal sinus. And see at this level, the maxillary sinus starts appearing. So now we have gone posterior to the frontal sinus to the level that we should be able to see the maxillary sinus as well. Sometimes at this point, you see a lot of pneumatization going above the orbit behind the frontal sinus when the maxillary sinus in view, and that kind of pneumatization going above the orbit is a supraorbital cell, not the frontal sinus proper, as you see the cribriform plate in view. That is most important. Let me bring the coronal section again. See this. That was the frontal sinus. As the frontal gone, now the cribriform appearing. See the cribriform plate? Very
Yes, sir.
clear?
Yes, yes, sir. Very clear.
Very clear. See the cribriform plate forming the anterior part of the ethmoidal roof. It has two lamella, the horizontal and lateral, and see the entire anterior ethmoidal cavities completely opacified bilaterally. With no distinction of cells and landmarks, it is completely opacified bilaterally. And the structure, the most important structure which I am trying to show here is the middle turbinate on either side, which is attached to the junction of lateral and medial lamella of the cribriform plate. Very clearly. Can you see this?
Yes, sir.
Or
Yes.
do I show in other view? See now much better. See, the another beauty of this dynamicity is you can change the window setting to see the bony and soft tissue things prominent differently. Now see, this is the bone, that is the cribriform plate, that is the middle turbinate, which is attached on either side at the level of horizontal and lateral lamella. This is how. So that is anterior ethmoidal roof. Now again, I am going back to the frontal. This frontal ended. I am going behind. The anterior ethmoidal roof appeared. I am going behind in the anterior ethmoid now. Far behind in the anterior ethmoid now. And at this point, can you see some beaking of the orbit?
Yes, sir. Yes.
On either side, this is the medial rector, this is superior oblique, and the confluence of these muscles, you see this beaking of the orbit, and that is where the anterior ethmoidal artery leaves the orbit to enter this lateral lamella, which is considered to be the thinnest part of the skull base. So what I'm trying to say, I'm going back again to show you so that you don't, frighten yourself all the time with the anterior ethmoidal artery. See, I'm going back to where the level of the ethmoidal artery, where the anterior ethmoidal roof is ending now to become the posterior ethmoidal roof. Now I'm coming back. See this frontal sinus? Now going behind, the frontal sinus ended, anterior ethmoidal roof started, see the cribriform, behind. So far, no anterior ethmoidal artery. So try to understand the anterior ethmoidal artery, see coming behind, see where the anterior ethmoidal artery comes, where the anterior ethmoidal roof ends. Do you notice this thing? And now, as you cross the level of the artery, the flat posterior ethmoidal roof starts. Can you see?
Yes, sir. Yes.
So let me take this to the 3-dimensional and show you how far behind this anterior ethmoidal artery enters into the skull base from the frontal sinus relationship. So that when you do the frontal sinus work, you are not always, terrified with the anterior ethmoidal artery. See, let me pick up the anterior ethmoidal artery on this coronal view here. See, that's the level of the anterior ethmoidal artery. Can you see? And
Yes,
now
sir.
see this level in the sagittal. see, if I draw a line here, this is the anterior border of the frontal sinus here. See this? Can you see?
Yes, sir. Yes, sir. Yes.
This is the frontal beak. See the level of the frontal beak. Can you see here?
Yes, sir.
And see how much behind the anterethmoidal arteries. When you are working with a 70-degree from here along the beak towards the frontal sinus, then you work along the ethmoidal roof there and see the arteries far behind this red line. See, so once you are working in this trajectory towards the frontal sinus, basically your artery is miles away behind in a different trajectory. I hope you got my point, what I'm trying to say.
Yes,
So
sir.
when you're working for the frontal sinus with a 70-degree, your artery is far behind. It is from here, yeah, I can say from here it is almost, see, more than 1.5 centimeter behind from the beak. Can you see this?
Yes, sir. Yes.
So don't get terrified all the time while you're walking along the beak for the frontal sinus that your anterethmoidal artery going to be anywhere close. This is far away, miles away, I can say, in my terms, away and in a different direction running along the skull bed. That is something you can extrapolate from your, CT imaging very clearly. Is that clear?
Yes, sir. Yes.
Now, importantly, before we go fast, this is, see, this was the anterethmoidal artery roof. As we go behind, immediately the postethmoidal roof starts. So the anterethmoidal artery runs in the posterior most part of the anterethmoidal roof where the postethmoidal roof starts. Then the postethmoid is is like a box bounded above by the skull base, medially by the superior turbinate here, laterally by the medial wall of the orbit, lamina papyracea, and then you go behind. See, these are larger cells. You can see the cell walls, but all white out, larger cell, as you go behind, larger cell. Now see, the roof is formed by the frontal bone. Entire ethmoidal roof is formed by the frontal bone. Keep an eye on the frontal bone from terial to terial on this frontal bone. As you go behind, now the frontal bone is leaving. And this lesser wing of the sphenoid has come. And when lesser wing comes, it is the sphenoid sinus behind. So this transition from the postethmoid to sphenoid is very important to know during surgery as well. As in the posterior lateral wall of the sphenoid, we have tigers running the optic nerve carotid artery. And we should know where exactly the sphenoid had started so as to orient ourselves, not to damage the structure blindly. So during surgery, at this point, I will show you when the transition from posterior to sphenoid starts. See this rostrum, and here comes the opening of the sphenoid sinus. So the moment, the sphenoid sinus comes, that is your limit that the sphenoid sinus is coming into the picture behind, and then staying anterior to the sphenoid sinus, you can complete your postethmoidal work without any, being terrified with the carotid artery or optic nerve behind, because all those structures are going to be always behind the level of the natural ostium of the sphenoid. In any given abnormal anatomy, the optic and carotid artery cannot come anterior to the sphenoid ostium. It has never been reported so far, and it cannot come. Simple. So the sphenoid sinuses, the multiple septation, incomplete septation, this is the real septation, that is incomplete septation. See the multiple as you go behind, incomplete, like frontal sinus, scallopings, and then these are the pterygoid process, so, and the plates. So in this, what CT scan, what we have found, what we need to notice is some important relationship with the skull base, the kind of cribriform plate, the kind of skull base, the kind of orbit, any dehiscence, anterethmoidal artery, all these things to be kept in mind to prevent complications. So this was a quick review of the CT scan, and the case is ready. In a couple of minutes, we are starting. Before is the time for any questions or any suggestions.
Yes, sir.
Hello?
It's a lucid presentation of, yes, sir. It is a lucid presentation of the radiology of the nose and paranasal sinus. and the importance of getting a digital images, especially a 0.6 mm cut with reconstructed images.
See, the beauty of digital cuts is you can share with your friends. You can tag on any particular anatomy and share them. You can, on your team viewer, run together from a distant site. Like my friend is in Singapore and he's in theater, he can share his CT scan lively. I can see on my computer his CT scan through TeamViewer and so many things. So this is something, and this is a something data which you can store for future, for your presentation, for future reference or future follow-up or so many things, because printouts is something nowhere, a substitute to this digital format.
Delegates. If
Any questions?
if
We have
there
a
is
couple
any
of
question,
minutes
you can
before I wash up.
yeah, you can scrub and start the surgery, I believe.
Okay.
We are eagerly waiting for your master. Sharif, are you there?
Any questions by the delegates?
Yes, you want to?
There are
Yes,
mics
Dr.
kept
Sharif
on
is
the
here. You can
auditorium. You all
speak
can
to him.
approach the mic and
Yeah,
Sir, I'm here.
Sharif, case is induced and
Yeah, the
draped,
case is
right?
induced. Sir is about to wash up for the case.
Okay.
Okay, sir. Thank you.
any doubts regarding any queries to Dr. Satish Jain, please come up. There are mics put up in the stage.
Audiovisual people, you can shift to theater, I believe.
मेरे को दे नहीं उससे वो था ना you can come you can you're part of the team today.
Dr. Sharif,
Sharif?
Hello.
can you give
We are
the,
getting CT image right now.
can you give the details of the patient?